Hello, welcome everyone. Thank you for joining us today. My name is Daria and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or chat box for comments you have throughout the webinar. Today's topic is emergency ultrasound, cases that change lives, and our speaker is Dr. Blivas. Dr. Blivas began his studies in aerospace engineering and computer science at the University of Michigan before shifting to biology and earning his medical degree. Dr. Blivas went on to complete an emergency medicine residency at the University of Michigan Medical Center, followed by an emergency ultrasound fellowship at the Christ Hospital and Medical Center in Chicago. He has held faculty positions in multiple universities and is currently a professor of medicine at the University of South Carolina School of Medicine. A pioneer in POCUS, he has published approximately 250 peer-reviewed articles, authored books, chapters, and edited 6 textbooks. Dr. Blivas is a professor of medicine at the University of South Carolina and a founding member and the past president of WinFocus and Sesame. He's also has extensive experience in the AI and machine learning application in ultrasound and currently chairs AI Community of Practice at the American Institute of Ultrasound and Medicine. Welcome, Dr. Blivas. We are so excited to have you with us today. Thank you for taking the time.
Thank you so much, Daria. It's really a pleasure to be here. All right, I take it that's my cue to launch into it
Yes.
and start sharing. Okay, very good.
Please.
Well, welcome everyone who is live and obviously watching the recording later. As Daria mentioned, there are people from all over the world, and I want to make sure that I don't go too quickly. So Daria, if you do notice I'm going off the rails, speaking too quickly, or using too much colloquial language, please let me know, or if there are any other issues. Otherwise, I will dive right into it. So again, the topic for today's webinar is emergency ultrasound cases, or emergency ultrasound cases that save lives. And I didn't want to just make a dry kind of academic talk, which I've done plenty of, and even cutting edge ultrasound, point of care ultrasound discussions can sometimes become very academic and dry. And I wanted to focus on cases that I learned a lot from. Sometimes I did something for the first time, sometimes I went out on thin ice, and sometimes I fell through the thin ice or simply missed things that should have been obvious to me, perhaps if I wasn't so focused on ultrasound or simply took a broader view of the patient. So we're going to discuss a few of these cases, try to understand some of the variation in emergency ultrasound practice and its adaptability. And I not only want to include cases that saved lives, and some of these did. Clearly, without ultrasound, these patients would not have lived, but also saved the day. And by that, I mean made a patient who felt horrible feel better, or turn a case that wouldn't have been fatal, but perhaps very time consuming or led to injury, but really saved that patient from worse challenges, worse injury, and saved the day for me. And we'll discuss a little bit about some future developments and challenges to emergency ultrasound throughout this discussion. Now, one thing I wanted to say right away is that emergency ultrasound, that's a name that dates back to the 1980s. And obviously, it's now evolved into point of care ultrasound, or POCUS, which is very inclusive of many specialties. Back then, it really was mostly emergency medicine, trauma surgery, doing very focused ultrasound in the fast. But otherwise, at least in North America, most other specialties had not really picked up ultrasound. Family medicine did for a while, but because of the way nuances of practice worked out in North America, they kind of let it go before picking it up again. And the concept of emergency medicine, I really wanted to stress, or emergency ultrasound, is that emergencies can occur anywhere. It doesn't have to be a big trauma bay like this with the resuscitation, perhaps gunshot patient or car crash patient. But they can be almost anywhere. They can range in size and grandeur. They don't have to be something that makes the television news. It can be something that's very important to a very unimportant person, unassuming patient in office or clinic or the emergency department or urgent care, where it really is an urgent matter and ultrasound comes through and saves the day. Um, One thing that I've really realized over the years is just how much learning and relearning I did through the practice of ultrasound in a clinical setting. I was shocked by how much material I really glossed over in medical school and should not have. But I was also somewhat shocked by the amount of information I learned in school and residency that was from the pre-ultrasound era and either no longer applied or wasn't quite right, or perhaps it was completely wrong. And so for me, discovery of all of these things has been a huge benefit of using ultrasound. Obviously, I think my patients have benefited too, and hopefully they would agree with that as well. So this is a good case to start out with. Uh, and it's one where I really learned to be aware of surroundings and also anchoring bias, which basically means that you decide that you know what somebody has, or let's say a nurse tells you, or somebody else tells you, a colleague that's another physician, what the patient must have for a diagnosis, and you latch on to that, and you either can't expand beyond it or have trouble. This is a case that occurred early March of 2020. I think most of us remember what era that was from. Uh, in the United States, COVID had just reached the coasts. I was working in kind of the middle of the United States, Georgia. We had not had COVID yet to any degree. In fact, I'm not sure we had any significant illness from it. So this is a patient that was a young man. Had some history of hypertension. Uh, Otherwise, no, he reported no past medical history, but it was clear he had hypertension. Smoked 3 packs per day for about the last 2 years. And he was sent home from his fast food job. I'm not sure which of the companies, but basically it was for coughing too much and having a fever. He didn't want to go home. He wanted to continue working so he can get paid, but was sent to us nonetheless. Symptoms were there for about 7 days. And he was a little tachypnic, 25, heart rate was up at 136. He was hypertensive. His oxygen saturation was 88%, and he was febrile. He had a few wheezes. I assumed after nebulized treatment, his oxygen saturation would improve. Chest x-ray was done in triage by protocol because we were very busy at the time and was read already by radiology as negative. And he was actually about to be sent home after some Tylenol. And this is where one of the times that being an ultrasound nerd benefited me and my patients. And again, there were probably times it didn't. And I expected that I would see something quite, benign, like this demonstration shows, maybe some B lines. I didn't expect to see, an abscess, effusion, any pleural line manifestations. Nothing really that exciting in this patient. But despite us being busy, I had enough time that I just had to scan his lungs at least. And I did that. I was actually surprised by the findings. And not only did I note B lines that were unusual, and it's unclear that they should be categorized as B lines at that time because of how abnormal the pleural findings were. And this is my first time seeing COVID lungs on ultrasound. There were very few descriptions of it very well, and there was still confusion about overlap between congestive heart failure appearance or pulmonary edema and COVID findings. But this is definitely quite abnormal and made me think COVID. So I ordered the test. It turned out it had been ordered fairly automatically at that time. It was taking 7 days to get a COVID test back. Some of you around the world may have experienced this, may have not. Um, but I accidentally got too close to the heart as well, and that's where I was about to receive some further shock. Um, there was no real reason for this young man to have a markedly decreased ejection fraction, and I calculated it. It turned out to be about 25%. I both did a visual assessment, and this particular vendor had an automated ejection fraction AI-based tool at that time, which agreed with me. And I realized the patient probably had myocarditis. I quickly checked the literature, and at that time, there were only two reports from Chinese cardiologists, uh, and they were indirect. They were published in some sort of note from the American Cardiology Society of Cardiology, and it simply translated two short descriptions of COVID-related myocarditis. Otherwise, there were no reports in the world. So um, it all started coming together for me. And remember, this is a patient I was about to send home, and my nurses quite appropriately were saying, "Get this patient going." Another physician at triage had said this patient just needed to leave. And it turned out that it was good. I didn't send him home. Interestingly enough, I had another patient like that that same day and ended up writing this up at that time. It was the first two myocarditis cases due to COVID or felt to be related to COVID in the States, um, and probably actually in North America. But I learned many lessons from that episode. Obviously, how connected the heart and lungs are. It was a very good reminder to always scan the heart if you scan the lungs. And there are people that advocate, I'm just a lung person, I'm just a heart person, but they really do interact. And there are so many disease states where it's good to check both. Um, I also learned just how close I came to missing a crazy finding because the lungs, obviously, the COVID lungs at that time by themselves were quite astounding. But to have the myocarditis with it really was important. And it was important not just for me, but for this patient's care. And I realized I should never be afraid to kind of short circuit the standard workup for the good of the patient. Because the patient's care plan changed completely. He was admitted, diagnosis of myocarditis was confirmed. He didn't quite go to the ICU, but spent some time in the step down. A COVID test did return 7 days later, and it was positive. And he eventually made a full recovery, but we could have easily sent him home, and perhaps he would have done worse. The community that I was working in at that time, if you sent a patient home, a lot of times they wouldn't return after getting a fairly full evaluation in their mind, unless they were extremely ill. And we saw that recurrently in the early days of COVID and realized that we had to be careful about who we're sending home and what instructions to give them. Um, Another great case that I learned something from, or many things, uh, involved relieving the worst pain ever. And this sounds very dramatic, especially now, but this was in approximately 2012, 2013, I believe 2013. Um, the patient is a 56-year-old male who presents with 2 weeks of worsening pain, and it's radiating from his ankle to his knee. The primary care physician has been managing the patient with increasing doses of opiates, has done some x-rays, other workup, it's all been negative. And to my surprise and disbelief, the patient is now taking 8 milligrams of Dilaudid total by mouth, already is on OxyContin, and I think maybe Vicodin as a baseline. For those of you in other parts of the world, Dilaudid is an extremely strong, both oral and IV synthetic opiate. OxyContin is very strong. And when I kind of put this together in my mind, I realized these were actually, or they should be fatal doses. So I didn't believe him. Gentleman was super nice when he could be because he was in agony, showed me his bottles, and I did call his primary care physician. Patient was very difficult to evaluate. He was crying, rolling on the bed. I wanted to send him for x-ray, but he was just in too much pain. So I thought maybe I could do something with ultrasound. This happened to be my first day at this facility, and I went and found the ultrasound machine. And the ultrasound machine, this particular one, was the same model, was probably released in 2003 or so, so 10 years old already at that time. I had not used it for some time. At that point of release, it was adequate image quality. It no longer was at the point I was going to use it. No one had used it in a while, had a lot of dust on it, and I've never actually visualized a nerve with such a machine. I've been spoiled and had higher end machines to do nerve blocks since about 2004. And mostly I'd done upper extremity blocks, femoral nerve blocks, fascia iliaca blocks, but I did do evaluations of the posterior fossa for things like this, Baker's cysts, obviously DVT, other things. And it occurred to me that the anatomy is there on ultrasound. If I could just find the nerve I needed to go after, I should be able to do the blocks I've done elsewhere. I just didn't know if I could do it with this particular machine. But the anatomy is really there. And what I was after was the sciatic nerve to catch some of the knee and especially the ankle, where his pain seemed to be emanating. I discussed this with the patient, told him I hadn't done this type of block before. And he said, well, do anything you can, even if you have to amputate it. He couldn't bear it anymore. So since we couldn't get him to x-ray without controlling his pain, and I didn't think additional opiates were a good idea, I was going to block him. And I thought this could be calling his bluff. I just couldn't believe the doses he was taking, and the none of this made sense. He had no obvious injury, no infection, nothing. So I did, in the back of my mind, reserve the possibility that this was a patient that was trying to get additional pain medications. But I was able to surprisingly visualize the nerve. It'll come up in just a little bit. Sciatic nerve starts coming out next to the popliteal vasculature, and surprising myself a little bit, was able to guide a needle to it and inject some bupivacaine with epinephrine. I had very limited variability in what I could get for anesthetics, local anesthetics, but this turned out to work quite well. And this is a block that I've done one version or another many times since then, but this is kind of my first impression of it, and it left quite an impression. So the patient did go to to X-ray, and I hear a code being called, code blue in this facility, and the patient returns back in respiratory arrest. Luckily, we gave him Narcan as we were bagging him. He came right back, and that's when it all hit me. The patient had hardware from an ankle repair decades ago that he forgot about. The nerve block provided complete relief and unmasked the effects of opioids. The patient was opioid naive before 2 weeks ago. So he had so much pain that he was taking what I felt could be fatal doses to a naive patient, and it wasn't controlling his pain. In the end, the patient was ecstatic. He did get a CT. There was hardware that was compressing a nerve. Orthopedic surgery was able to go in later that day while the block was still active, actually, in the OR, take out the hardware, and the patient's pain never quite returned. He did have some discomfort for several days, but was completely relieved afterwards. So this was a case where I discovered many things. Obviously, the power of ultrasound, intervention with ultrasound, and just how careful I had to be about making assumptions and always looking for the underlying etiology when things didn't make sense. Speaking of pain, another major pain point for me for years, really since residency, was placing transvenous temporary pacers. As you know, symptomatic bradycardia or asystole can present to the ED. They can develop in the hospital. I've seen people present to clinics and primary care offices that are in third-degree block, hypotensive. They can degenerate to a rest state. I've seen patients have pauses of 10 seconds and obviously lose consciousness. And some respond to chemical management or intervention, but some don't. And pacing can be life-saving. Typically, in the emergency department and many other settings, transcutaneous pacing is kind of the standby. It it's not quite as effective as we're taught, especially as patients around the world, especially in North America and Western Europe, enlarge because of obesity and the insulating properties of fat and just the distance to the heart. We often don't get the best capture, and sometimes not at all. And because of that, transvenous pacing has a lot of advantages. You're almost guaranteed capture if it's placed correctly and the heart is willing to work. And it's much more comfortable for the patient rather than having to be shocked. And this is actually a portion of a study I did some years ago. I'm not sure I ever quite wrote it up, but it was a personal kind of journey through doing transvenous pacemakers because I found them very hard to do. Often didn't have access to fluoroscopy, and doing it blindly was very challenging for me. Trying to look at pacer spikes or actually QRS spikes on a monitor. And I wanted to see if I could cheat or short circuit this process for myself and do it better. And what I used is ultrasound, not just for placing the central line, let's say in the neck or subclavian through which I would feed a transvenous pacemaker, but actually guide the pacemaker myself. And obviously, we do use the subcostal approach quite frequently. And this turned out to be a great way to monitor pacemaker entrance. In fact, if you just adjust this probe and rotate it, you can see the inferior vena cava. And sometimes if the pacer doesn't appear in the heart, you can actually track that it's gone into the inferior vena cava. And you also have two other locations to use for imaging, the peristernal and the apical. So you should be able to visualize pacemaker lead as it's coming in fairly well. This was a study that went on for years, included multiple different machines and several different providers placing it. After a 7-year period, there were 60 patients that received transvenous guided pacemakers. All of them were unstable, kind of one of our criteria. And we were successful in placing 98% of them into the right ventricle and paced 83% of patients. And you can see an example here where the heart is obviously in trouble. This patient is in trouble. Transcutaneous pacing isn't working well. And this is a video clip that's edited a little bit. So it combines a couple of different segments, but you can see where the balloon is in the right ventricle. And shortly after this, pushed the balloon through just a little bit further, deflated it, and we had very good capture. Now, the most frequent window we used was the subxiphoid, but second most frequent was the apical four-chamber, which in some patients lent a great imaging window, and others was obviously horrible. There were 2 cases of equipment failure. One was successfully corrected and the patient finally paced. Other one, the equipment failed. Another reason somebody couldn't be paced was severe beta blocker overdose. It was actually a combination of beta and alpha or calcium channel blockers, and then severe ischemia. So for the majority of patients, this worked very well. Sometimes it was life-saving. And for those that were awake, it increased their comfort quite a bit. Causes for the bradycardia varied, including third-degree block, hyperkalemia, ischemia. I was surprised by the number of severe hyperkalemia cases, overdose, tachybrady syndrome, and some unknown causes. This is another example of a patient that was best visualized using the apical four-chamber view, and you can see providers having some difficulty getting past the valve on the right side, and with careful timing, I think this video shows at least a little bit later, we're able to get the pacer lead with the balloon up to go through the tricuspid valve and successfully pace. And oddly enough, we're actually pacing from the valve location right there because the patient was severely bradycardic. And this was an interesting lesson too in not focusing too much. Those of you watching the video, if anyone's noticed this mass-like structure in the left atrium, this was actually missed by all of us until video review later that day. Luckily, the patient was admitted and cardiology was already involved. But that was quite amazing that we all missed this, what appears to be a fairly obvious finding. And here's the transvenous pacer going through right to the apex. It did take a little while to get it through there. Tricuspid valve did not want to let it through, but we were quite confident and didn't have to expose the patient to radiation or ourselves. And it's unclear how we would have done that in real time. So in conclusion, using this methodology, successful placement occurred in 98% of patients, and capture failure was really due to severe myocardial dysfunction of various etiologies. All right. Now I wanted to talk about scary procedures made less scary. And the transvenous pacemaker wasn't necessarily scary. It was just too difficult for me without ultrasound, perhaps based on my skill level or laziness, what have you. But what I found to be a really scary procedure was draining a peritonsillar abscess. Traditionally done with a scalpel, like here, you just kind of incise it. You incise it blindly. I think we all feel that ENT is perfect at this, but they can have a 15 to 20% failure rate, even taking multiple stabs. The part that always scared me is how close the carotid artery was behind where the abscess is located, and there are cases out there of death and significant disability from damage to the carotid artery or seeding it. So I definitely would not stab with a scalpel. I did try in residency a couple of needle aspirations that scared me plenty, and I was really reluctant to do it in practice. But early on in my fellowship, I was faced with needing to drain a peritonsillar abscess in the middle of the night, and I realized I needed to do something different. And what I came up with, and I couldn't find anybody else doing this in the literature, at least in 1998, was taking an endocavity probe, obviously cleaning it thoroughly, sheathing it, and using that after medications to overcome trismus to image the peritonsillar pillar. At a facility I ended up working for about 5 years in southern Georgia, we actually got very good at this. And after several years, we were so accurate that ENT clinic would actually refer patients down to us. It was more effective for them than trying to book them for the OR. Sometimes we would get rare ones like multiple POCUS from ENT, and the peritonsillar abscess either didn't exist or was in a very unusual location, very high typically. Obviously, we saw many dry taps that were to become a peritonsillar abscess and even followed them in the emergency department. Typically, this would be an easy drainage. As you can see here, a fairly sizable peritonsillar abscess right against the probe. You can guide the needle directly into it. The syringe and needle are placed next to that ultrasound transducer in the mouth. And periodically, we encountered small peritonsillar abscesses and were surprised, or we couldn't get any fluid back. And 2 days later, we could, and many negative ones as well. But one that sticks out specifically is a little bit different, and it was a surprise call from an outside facility in the middle of the night. The facility was only about 50 miles away, and I got a call actually from our chairman of plastic surgery. As you can imagine, when the chairperson of plastic surgery calls you, it's a big deal. And he said that he's accepted this transfer. His service was on face trauma and facial surgery because all of the facial surgeons were actually away at a conference on the other side of the country. He said I could call him and he'll even come in, but he has no idea what to do. And what was being transferred was a labeled as a perivertebral abscess from this facility in a patient that was still able to breathe but couldn't swallow and was having increasing distress. As you can imagine, this could be impactful for intubation. So we were very eager to look at the patient. He was fairly cooperative, and after being properly medicated, I decided to take a look. And this is not the peritonsillar abscess. Each one of these is a centimeter. Before, this would have been the abscess, but it turned out to be this far away. And I realized this was a retropharyngeal abscess, basically, just as the CT showed, and that I could probably reach it with a needle. A standard 18 gauge needle did not work. It wasn't long enough, even being 2.5 inches, a little over 5 centimeters, I believe. I apologize for not being able to do metrics quickly. But I eventually found a 4-inch needle, so this would be probably 9 centimeters, 10 centimeters. Again, my apologies. And 14 gauge is a very large one. This was from a very large old IV, and I simply took out the needle inside. And after the patient was as comfortable as I could make him, guided it right into the retropharyngeal abscess. And there are cases reported, obviously, of retropharyngeal abscess drainage. It's almost always surgical. At that time, I wrote up the case. I had never seen and could not find any published reports of transoral needle drainage of retropharyngeal abscesses. I did check a few years ago, and I think I still hadn't found one. Perhaps somebody's done it since. The write-up of the case, I believe, was several years after the actual case. The case occurred, I guess we could maybe tell here, in 2004. I don't think I wrote it up for another 5 or 7 years. But it was amazing to me, that I didn't pass out from being terrified. And that was probably only because I was short on coffee and this was the middle of the night by the time I did it. And that it worked. I didn't injure the patient. The patient tolerated this well. We pulled off approximately 23 cc's of green pus. And I ended up admitting a patient overnight in our observation area with IV antibiotics, sent him home with orals, and he did great. And what was interesting is he could barely talk. He was a perfect patient because he was in such discomfort, he couldn't move his neck. He couldn't turn his head, couldn't even pull away from me in the chair. So I was able to do this. And once I aspirated all the fluid I could, he sat forward, rotated his head, turned around a little bit, said thank you, and asked if he could now leave. So I just about fell over backwards. But to me, it was a great lesson in following the basic principles and simply extending what may be done normally as long as you do it safely. And ultrasound allows you to do that. It allowed me, and there's zero chance I would have ever done this blindly without being able to see it. Another case that I think was very illustrative for me, I termed peeling back layers with ultrasound. And these are layers of deception, so to speak. The deception that complicated cases throw at us, helpful people end up throwing at us, and what happens when you get a lot of different information in a critical moment. And ultrasound can sometimes, for me, really help dissect through that and get to the core of the problem and sometimes fix it. So this is my last day in the job in the emergency department. I was working at 2 different ones at the time. And I was leaving this one because of the low acuity at this location. The other one saw sicker patients. And it's very ironic. I'm walking out the door, but a few minutes early, after clearing it with the charge nurse, and I get outside, I'm walking towards the parking lot, and the charge nurse runs out and calls me back. In another pod or portion of the emergency department, there's an emergency physician and the physician assistant from the ICU struggling with a septic shock patient who's rapidly deteriorating, and they're attempting to scan the heart, but aren't quite sure what they're seeing. This is not that patient, but this is a case of ultrasound differentiating shock diagnosis and managing it as well. It's important to recall the different types of shock. And obviously, as a septic patient, this patient would have distributive shock. So I focused in on that. I'm expecting to see some myocardial depression, maybe like this, but not something very, not EF of 10, let's say, or something completely different. I'm thinking about looking at the IVC, estimating the VTI, the cardiac output, possibly search for sources of infection. And in particular, this was a 55-year-old male, nearly in arrest, thought to be in septic shock. He did have a mild temperature elevation, but probably not a fever. By the time I got to him, blood pressure was 61/30. Heart rate was in the 160s. Level of consciousness was worsening. He wasn't responding very well. So I was going to do, standard things. But when I got there, the two providers already there are looking at the patient, scanning him, and they're not sure what they're seeing. I take a quick glance and I say, well, it looks like you have some evidence of tamponade on ultrasound that goes along with the physical findings, the vitals, although we never thought it would be from tamponade. And there is a pericardial effusion that's, depending on when you look at it, could be considered medium to large. So neither one of the, excuse me. So I tell them that, and I say, it's best to do a pericardiocentesis emergently. I'll see you later. But they tell me neither one has ever done a pericardiocentesis. So I realize I'm staying a little bit longer. And that's not a heroic part. That was fine. For a chance to steal a procedure, I would definitely stay. So we start down the pericardiocentesis path. Don't have necessarily the best probe for this. There was no linear, but using a curvilinear, the orientation is backwards. I drive a needle in, and we'll actually see a little bit of a flush of sterile saline just to make sure we're in the right space to confirm needle localization. We did not have a pericardiocentesis kit, and I used a monolumen central line kit, fed the wire over the catheter. And while we're here, take a note of some of the material here. It's oddly echogenic, and I probably didn't pay as much attention to that as I needed to. The next video here shows something that I missed initially, which is how dilated this root is, the aortic root, and probably a hint of a flap. We see that pericardial effusion here. Again, so almost certainly this is a dissection, and these are clots. I've not seen anybody really recommend doing a pericardiocentesis for dissection, but we are out of options here. And I've opened up chests emergently in facilities with no cardiothoracic surgery backup for dissection, and uniformly those patients expired immediately. So unfortunately, that first central line I put in, when I withdrew the wire, introducer wire, it unwound. And a wire that's this long actually became meters long. I was shocked. So I couldn't get it out, left the line in, and ended up having to put in something larger. I knew that was our only hope for pulling back some blood, being able to get some portion of the clots out. We couldn't use a thin line like a monolumen central line. So here's the cordis introducer sheath introduced. The other line is still in here. You kind of catch it occasionally. And we pulled back about 80 cc's of blood as the patient was about to be intubated. It was so chaotic. He hadn't been medicated yet. He was being bagged, and his vitals improved dramatically. He sat up, which caused some problems. We quickly laid him back down, started speaking. In the end, the patient had to be transferred. This facility was small enough. We didn't have cardiothoracic surgery. we were outside of a major metropolitan area, and the hospital would be about 30 minutes away. That was the receiving. They accepted it immediately. The cardiothoracic surgeon was very nice over the phone. And the problem was the time of day. It was rush hour traffic, so it would be probably 2 hours by ambulance. So we decided to fly. The flight crew gets here, loads the patient up, leaves, and I learned later what happened. Uh, Freak storms come in, including tornadoes. They're forced to do an emergency landing, but not a crash landing, in a parking lot in a mall, shopping mall. Uh, Ambulance is eventually dispatched. Instead of taking half an hour to get to this facility, the patient takes 4 hours. He survives. Cardiothoracic surgery repairs my kind of exploration there, takes out the wire, fixes a dissection, and the patient lives. So some quite amazing lessons for me. Even though I'd heard no one really recommend, and I've been told, I don't recall if I read in the literature, that it's pointless to try to draw out a clotted effusion like this in a pericardial effusion case. I have seen and read that if it's liquid blood, that you can maybe do it. And this was a combination of both. But there were no other options. And I used what I knew from ultrasound, placing central lines, used what was available. And fortunately, not through my skill, but through ultrasound and the help of many people, the patient survived when I really didn't think so. Here's another case that I wanted to get in, partially because I really did something I never thought I would or would have reason to. And that's why I titled this Crazy Thoughts Expressing Safely Through Ultrasound. Because it was a crazy thought to think what I ended up doing, I feel, still probably. So this is a 22-year-old female in distress, complaining of shortness of breath, difficulty speaking, holding her neck, and she was in real distress. She has a history of severe laryngospasm and actually even intubation. Her parents were with her. They were visiting the area, and they confirmed this. I didn't really believe it, but I said, absolutely, I understand. She was tachycardic, had an elevated respiratory rate. But again, I had trouble believing the story of it. Fortunately, I knew that we could image the airway. I've imaged cords before, but really more for, I imaged the trachea for cricothyrotomies and things like that. But if you recall, here are the true cords, false cord, the aeroepiglottic folds. A lot of this can be seen on ultrasound, especially depending how you're located on the neck. And in this case, I decided to use ultrasound to either confirm or refute. And to be honest, I thought there was probably a slightly greater than 50% chance that I would see those cords normally functioning. I would be able to show this to the young lady on ultrasound and say, I don't think this is the case. We'll get some other things done, but be relieved. You should be breathing okay. And this is what I saw. These are the actual cords. You see some bright echoes in the middle here, gas. And this is basically gas within a little bit of sputum. And no matter how hard she tried, she couldn't really speak normally. And she cannot get those cords to separate. So that's when I realized I had to believe her. And everything the family told me was true, and began to figure out if we're going to have to intubate her like she had been a year previously with another severe episode like this. Obviously, she was eager not to be intubated, and so was I. Unfortunately, I left my Botox supply at home, and I'm not sure I was going to stick Botox anywhere around here, and Botox takes time. So while thinking about this, I realized that I did a lot of interscalene blocks, and periodically I would accidentally block the recurrent laryngeal nerve and paralyze one of the cords ipsilaterally. And this was unintended. It was I could change location of my block to decrease the incidence, and decreased the amount of anesthetic I used. And over the years, I was successful in doing that. But I never thought that maybe I would block the recurrent laryngeal on purpose. I went to the internet and any source of anatomy I could find at that time in the middle of the night, and realized that the recurrent laryngeal would typically sit here. But for some reason, when I traced hers, every time up and down, it seemed to lateralize here. I didn't know if that was really true or not, and I decided to inject enough so that I could dissect down and probably end up by the thyroid. This was actually, I edited this video and this portion is sped up significantly because I wanted to do a small test injection, see how the patient tolerated everything. He was hooked up to monitors. But in time, I did get a very nice layer of anesthetic, and I wanted to, I eventually injected her with bupivacaine with epi. That was the longest acting anesthetic I had, local anesthetic. I did see in time that it kind of dissected down to this region, so I covered everything I could, having doubts about my visualization of where supposedly the recurrent laryngeal went. And it turned out the patient did rather well. And I have proof of that, not only her telling me, but this is almost immediately after, maybe a minute or so if I recall. But notice this cord where I injected, the ipsilateral cord, starts moving. It wasn't before. Another 5-10 minutes later, the patient could speak, although hoarsely, and said she felt great. And we were able to get her seen in ENT probably about 5-6 hours later. So not anything I ever thought I would do, especially intentionally, but that's the potential of ultrasound to kind of make your crazy thoughts be safe, but also innovate or discover something new for yourself. Do extra for the patient that you could not have thought before, and I think that's a wonderful aspect of ultrasound, wherever and whatever the emergency is. So, in summary, ultrasound can enable life-saving, or, as I mentioned, day-saving, saving somebody's day, perhaps yours or the patient's, whether it's controlling their pain or helping them breathe better. It may not be a grandiose act like in a trauma bay, but it's plenty important to you and the patient. Patients definitely don't care if you help them, with your toolkit and expanded, and actually discovering new applications yourself and learning new skills can be driven by need, and doing so with ultrasound is really incredibly fulfilling. That is the end of my presentation. I'll stop sharing and thank you all for watching and listening. I really appreciate it.
Thank you so much, Dr. Blevis, for your presentation. Everyone, please submit your questions in the Q&A box, and we'll go ahead and launch our webinar quiz that Dr. Blevis put together for you guys, so you can test your knowledge and see what you learned. So you should see the 3 questions pop up on your screen. We'll give you a couple of minutes to respond to those, and then we'll move to our Q&A portion of the presentation. So I see everyone is answering. So feel free to just get to those questions and share your thoughts with us. And if you have any questions, please submit them to the Q&A box. All right, so you have 30 seconds left to participate in the quiz. This is not mandatory. This is just to see some more engagement with you guys. So please feel free to respond to those, and we'll move to the Q&A portion of the webinar. And again, if you have any questions about the presentation or any other questions about the content, feel free to submit in the Q&A box. All right, let's see the results, and I'm going to share the correct answers. All of them. Dr. Blivis, would you like to comment on any of the results?
Sure. I had originally meant to include more data that didn't make the final cut. But traditionally for the subxiphoid approach in terms of pericardiocentesis, that's how I learned it. First blindly in medical school and residency, and then I incorporated ultrasound. And other approaches were kind of frowned upon. There were some apical ones described. But Mayo Clinic did a very large study, I think perhaps in the 1990s, over 1,100 patients using the parasternal approach, and they found that to be the most efficacious and have the lowest complication rate. So that is probably the best approach. If you think about it too, with a good probe like a linear or curvilinear, you can see everything from skin to the pericardial effusion. Obviously, you can't see the heart there. That's a limiter, but whenever there's a fairly sizable pericardial effusion, it moves the lung out of the way, so you should be able to get a good image, and you can guide a needle very precisely. Temporary transvenous pacemakers, again, ultrasound, I think, in many settings is ideal. But if you have fluoroscopy available, you're an interventionalist that uses it all the time, obviously, that may be your choice over ultrasound, and that's quite reasonable. Ultrasound-guided regional nerve blocks. There are many studies that show decreased opioid use from preoperative regional anesthesia, intraoperative, and then post-op. Some of the data is still emerging, but obviously the case I presented, clearly the patient was on what I would consider massive doses of opioids because the primary care physician knew the patient, believed in him, and wanted to make him comfortable and was doing all he could. And then interrupting that pain signal that was so horrible caused their respiratory arrest. So that was just a kind of in-my-face example of the power of regional anesthesia and its benefits over opioid medications.
Thank you so much for commenting. We'll go ahead and move to the Q&A portion of our presentation. I will also be sharing another poll for you guys, so if you can, while we're doing the Q&A, help us answer some questions. And this will help us to plan future webinars. And let's see if we have any questions submitted. So we have one question from Sarah. You mentioned using automated EF. Curious what your experience has been with other AI features, automated A-line detection, etc.
So I have had a fair amount of experience. I've also, that particular EF feature, I helped develop it. So obviously the challenges are when imaging is limited or when you train the algorithm without capturing enough data at either extreme. So for auto EF, for instance, very low or very high EFs are a challenge. A lines, B lines, etc., plural lines, those are fairly easy to detect using actually kind of off-the-shelf neural network algorithms. And there was a nice study by Dr. Arnfelt around this time in how an algorithm that didn't specifically look at anything such as a B line or A line or the plural line, but just in general looked at the entire image. So it's a more rudimentary algorithm, could differentiate between patients that were in the ICU with respiratory distress syndrome, congestive heart failure, and COVID-related respiratory failure. And they did something called heat mapping or saliency mapping, which is looking at which pixels are most important for the algorithm and making its decision when it's correct. And it turned out that actually the pleural line in this case was the most important. And I think there's good data to suggest that that's the best way to differentiate COVID findings from others. So as long as the algorithm is properly trained and vetted, I think you could get very high accuracy, and especially not just detecting normal anatomy, but identifying abnormal. I hope that answers your question.
Thank you. We have a question from Jose. In hindsight, doing that I'm sorry, I will not pronounce this.
Pericardiocentesis.
There you go. Using ultrasound and knowing that the fluid was a mixture of clot and blood fluid, how would you have done that procedure to evacuate it?
So unfortunately, I had no cardiothoracic surgery backup at that facility. Really, no one that would back me up if we opened the chest. And probably about a year before that, I opened up a chest on a 33-year-old that came in an arrest. Turned out he had a pericardial effusion. It took me a little bit, but I put together that he was dissected, could see the flap. Could not drain anything. I tried tapping him a couple of times. We were basically losing the patient, and the patient's family was there. So I opened up his chest as a last minute or last second decision. Instantly, I was covered in blood, and my nurse and the wall, and the patient expired immediately. And I've seen this or had it a few other times. So in retrospect, I'm not sure I had any other options. To be honest, had I known, I may have stalled too long. So it was the heat of the moment that drove me forward, and it was probably to my benefit. Otherwise, I may have lamented too long to make the impact.
Thank you so much for sharing the story. We still have 2 minutes left before we concluded the webinar. So if you have any additional questions, this webinar was recorded, so it will be shared with you next week. Please stay tuned for that. And thank you for sharing your feedback with us via the question that you see on your screen. So you still have a little bit of time with Dr. Blivus, but before we conclude, I wanted to thank you, Dr. Blivus, for your time, for your wonderful presentation. We hope to see you present with us in the future. And yeah, if you have any questions, please reach out to us. Again, thank you so much, Dr. Blivus, for your time.
Thank you, Daria. Thank you to everyone who attended. I really appreciate it.
Well, with that, we'll conclude the webinar for today. We'll see you next month. Actually, we have one more additional webinar in July, and August is our MSK month. So we'll see you in the next webinar. Thank you so much, everyone. Have a great time. Thank you.